Good afternoon and welcome to the webinar, Expanding Access to Medication-Assisted Treatment in Residential Addiction Treatment Programs. This webinar is the first in a series of webinars that RTI is hosting, focused on improving the quality and financing of behavioral health services. My name is Tammy Mark and I am the Senior Director of Behavioral Health Financing here at RTI. RTI is an independent nonprofit research institute dedicated to improving the human condition. I'm in the Division of Behavioral Health and Criminal Justice, which employs over 250 professionals dedicated to identifying opportunities to reduce the impact of substance use and mental health disorders. I want to go through a few logistics before we get started. At this time, all participants are in listen-only mode. For those of you who have dialed into the meeting, you will want to mute your computer speakers so that you don't have an echo. The first thing that I'd like to draw your attention to is our chat pod, which is located on the left of your screen marked chat. This is the best way to communicate with us if you're having any technical difficulties or questions regarding today's materials. Later, we'll conduct a question and answer session and open it up and unmute you. Please note that this conference is being recorded and that the recording and the slides will be posted on the RTI website. So in today's webinar, participants will hear from addiction treatment residential providers and policymakers in Virginia about how they have developed processes to provide medications to treat opioid use disorders within their programs. We have a packed agenda. I'll begin by providing a brief summary of the effectiveness of opioid use disorder medications. Then you'll hear from Dr. Matthew Keats, the Behavioral Health Medical Director of the Virginia Department of Mental Health and Addiction Services, about how Virginia is expanding access to OUD medications. With that context, you'll then hear from 3 providers in Virginia about key lessons learned from implementing MAT, such as ensuring that all staff within the organization buy into the importance and value of MAT, building relationships with prescribing professionals, pharmacies, and health plans to ensure access, and ensuring that when patients leave your program, they are connected to services so that they continue to obtain their medication, and many other important insights. So let's get started with a brief background about the effectiveness of medications to treat opioid use disorders. I'm constantly amazed, given how much attention the opioid epidemic has generated, how little the general public knows about medications to treat opioid use disorders. We know from scientific studies conducted by NIH and other research institutions that over time, drug use changes the structure and working of the brain. Brain imaging studies of people with addiction show physical changes in the areas of the brain that are critical to judgment, decision-making, learning and memory, and behavior control. And scientists believe that these changes may help explain the compulsive and destructive behaviors of addiction. The hallmark of addiction, of course, is the fact that while the initial decision to take drugs is typically voluntary, with addiction, a person's ability to exert self-control over that use is seriously impaired. In the U.S., the FDA has approved 3 medications as safe and effective for treating opioid use disorders. They are methadone, which is a full opioid agonist, buprenorphine, known as under the brand names Suboxone, Subutex, and Ibuprofen, which is a partial opioid agonist, and naltrexone, which is an opioid antagonist, which is available in a long-acting injectable form under the brand name Vivitrol. These medications enable people to counteract addiction's powerful disruptive effects on their brain and behavior and to regain control of their lives. Nearly 2 decades of research, represented by many randomized clinical trials, find that methadone reduces opioid use relative to drug-free treatment and improves functioning in major life domains. As you can see in the slide to the right, the average effect size across these studies is large. Although newer than methadone, a significant number of high-quality studies also find that buprenorphine reduces opioid use relative to drug-free treatment. And long-acting injectable naltrexone, again sold under the brand name Vivitrol, has also been found to be effective in reducing opioid use among those who are able to withdraw from opioids prior to taking naltrexone. As shown in this slide, long-acting injectable naltrexone reduces craving in a manner similar to buprenorphine. And most importantly, we know from cohort studies that have followed people on and off of methadone and buprenorphine that these drugs save lives. I know this is a busy slide, but if I draw your attention to the lines in the middle, they show the all-cause mortality rate for patients when they're on methadone or buprenorphine, and then the mortality rate when they're off of these medications. And off of the medications, the mortality rate is 2 or 3 times that when patients are on the medication. So incredibly effective medications for these disorders. Remarkably, given the effectiveness of these disorders, very few outpatient or residential substance use disorder specialty settings offer them. Only 30% of residential treatment facilities offer MAT, according to SAMHSA's surveys, and only 22% offer injectable long-acting naltrexone. So with that background, I'm very pleased to introduce Dr. Matthew Keats from the Virginia Department of Mental Health and Addiction Services.
Good afternoon, everybody. Today, I wanted to sort of build on what Tammy was just talking about from the perspective of Virginia Medicaid, also known as DMAS, Department of Medical Assistance Services, and what we've done here in Virginia to, as part of our arts program, to try to improve access to medication-assisted treatment. Let me just tell you a little bit. I know some of you in the audience are based in Virginia, some of you are not. So particularly for those of you who are not, April 1st of this year, we launched our ARTS, our Addiction Recovery and Treatment Services program, done under a 1115 demonstration waiver through CMS. We went from essentially having a very inadequate and rudimentary continuum of care for our members with substance use disorders to really having a full array of services built sort of on a chassis of the ASAM placement criteria. So really for sort of going from 0 to 60 in under 10 seconds. Though, needless to say, once the program started, there's still been a lot of work getting it fully implemented. Some of this, like I said, is going to build on what Tammy just said. I'm going to approach some of the same studies from a slightly different perspective. So I just want to really reiterate, and I'm not that just that the use of medication-assisted treatment improves lives, but it actually saves lives. Not only through decreasing the rate of overdose death, but actually also because there are so much medical comorbidity and other bad outcomes associated with active addiction, opioid use disorder in this case, that there's also a life-saving benefit above and beyond the impact on reducing the risk of fatal overdose. Retention in methadone and buprenorphine treatment is associated with substantial reductions in risk for all-cause and overdose mortality for people with opioid use disorder. I believe it's the same sort of busy slide that Tammy just showed, the same study, the British Medical Journal medical meta-analysis. The study goes on out to a period of 4.5 years. So not just looking at the immediate period after treatment is initiated, but over time. Continued use of opioid agonist therapy after incarceration, which of course is a period of enforced abstinence, reduced the risk of death by 75% compared to those on no therapy. In the case of this study, which was from an Australian setting, methadone reduced the risk of death almost 5 times in terms of overdoses and over 3 times in terms of all-cause mortality. Likewise, buprenorphine reduced the overdose risk by over three times and over twofold in all-cause mortality. And the study showed a suggestion that buprenorphine could lower the risk more than methadone, especially in those first early weeks of treatment. Another study from the journal Addiction showed that the risk of overdose death for patients receiving only psychological support for opioid use disorder was double the risk for those receiving opiate agonist therapy. I believe that was in combination with counseling. So once again, just really want to drive home the fact that this is life-saving treatment. I think the slides may be slightly out of order here. I've already really told you some about our arts program. The demonstration waiver that we launched under allowed federal matching Medicaid dollars for substance use disorder services for facilities with more than 16 beds. As some of you in the audience may know, previously those facilities were excluded because of the IMD exclusion, but the waiver allowed us to pay for treatment in those settings, residential settings. It didn't change who was eligible for treatment. That is to say, our population base didn't expand, but we added this very robust benefit to the benefit for Medicaid recipients. CMS, under the terms of the waiver, requires an independent evaluation and periodic updates of the impact of the waiver. Since they have provided significant matching funding for us, they want to make sure it's being put to good use. So because of these things, arts dramatically altered the landscape for residential providers. In addition, reimbursement rates prior to arts for residential treatment were really inadequate. And we understood that actually very few residential providers, understandably, were willing to participate. But the rates have now been increased by more than threefold, and all 1.1 million Medicaid members are now eligible, those with substance use disorder, for residential treatment, if that's appropriate under the ASAN placement criteria, which is, as I said, really the chassis on which this program is built. So that not only significantly improved the reimbursement rate, but significantly expanded the population base eligible for treatment in a residential setting. This just graphically or pictorially shows the same thing in these maps, these geomaps. Orange means lack of available services, and the shades of blue mean increased availability, in this case of residential treatment. So we went from a total of 4 participating residential treatment providers to now 78, so that the vast majority of the state now, our members have access to residential treatment providers. And that, of course, is a very good thing. A really important development in all this that is required for every state, not just Virginia, operating under the 1115 Substance Use Disorder Demonstration Waiver. A letter went out from CMS at the beginning of November of last year to all state Medicaid directors, requiring states, I'm just quoting directly from the letter here, that residential treatment facilities must offer medication-assisted treatment on-site or facilitate access off-site, and that means during the period of residential treatment, not afterwards. CMS will monitor how effectively states ensure sufficient provider capacity at critical levels of care, including medication-assisted treatment for opioid use disorder. So CMS has really taken a clear stand here based on the evidence, the kind of evidence that Tammy and I just cited, of making sure that residential treatment facilities are offering medication-assisted treatment, or at the very least facilitating off-site access. Accordingly, by the end of 2018, we, Virginia Medicaid, will require all our arts residential providers to demonstrate how they are providing medication-assisted treatment or facilitating off-site access to medication-assisted treatment for our members with opioid use disorder. Last, we will have in the not-too-distant future value-based payments, part of a larger initiative for value-based payment reimbursement across the benefit for residential treatment, and that will include the percentage of members with opioid use disorder who receive MAT at each residential treatment program. So that is to say, those programs who provide it more robustly will receive an enhanced reimbursement, and those who provide it less robustly or not at all, a reduced reimbursement. We take this very seriously. Last, we realize, and I know from our providers who are about to speak for the rest of the presentation, there are a number of challenges that exist in making medication-assisted treatment available in residential settings. Some parts of you guys in the audience live in or work in parts of the state where there are a lot of providers, waivered providers. Some of you work in parts of the state or the country where there are very few. Here in Virginia, there are a number of tools that we offer to help programs, residential programs, and other providers identify what resources are available. Our website, and I encourage you to visit it through that link, has a Google map which shows the location of every arts provider of any type other than outpatient in Virginia and neighboring states, ASAM levels 2.1 through 3.7, including their contact information. And this includes all our office-based opioid treatment programs and opioid treatment programs. There's a searchable list of all the arts providers, levels 2.1 through 3.7 by region, and also a SUD email address for any questions. I think that's on the last slide. Also, all the managed care organizations, we have 6 here in Virginia that manage the arts benefit on our behalf, have full-time arts care coordinators who can help identify waivered practitioners and other resources and help link patients, that's really their job, and residential treatment providers to these practitioners. I will end my presentation here and pivot to our providers.
Thank you so much, Dr. Keats. So our first provider is Richmond Behavioral Health Authority, John Lindstrom and Jim May. And hopefully you both have successfully logged in, and look forward to hearing from you.
We have indeed. We are having a little technical difficulty in the audio, and so the clarity may be just a little off. But thank you for having us be part of this, and good afternoon to listeners. The Richmond Behavioral Health Authority is the local public authority responsible for providing mental health, developmental disability, substance use disorder, and prevention services for the city of Richmond. The city that's a little over 200,000 individuals in population. In 2017, RBHA served over 12,000 individuals, representing about 6% of the city population. As most people know, wait times present particular problems, especially for those with addictive disorders. And we saw our wait lists grow to about 6 to 10 weeks for many of our services. In the past 6 years, though, the city has also seen dramatic increases in heroin and fentanyl overdoses. So as the slide suggests, in 2011, there were about 8.76 per 100,000 reported, but as recently as 2017, 30.4 per 100,000 were noted, probably because of more fentanyl exposure in the community as well as heroin purity. So to move on then, historically we provided outpatient, intensive outpatient, and case management services for individuals with substance use disorder. But we purchased MAT and residential SUD treatment services from separate and private providers during the course of that time. However, because of some struggles in the provider community, we moved forward a couple of years ago to expand our own directly provided services and to improve the general availability of SUD services within our community. We acquired and began directly operating a 13-acre residential SUD treatment campus, which includes withdrawal management services and 3 separately licensed residential treatment programs. Each of the programs, after we acquired the space and had an opportunity to move forward with licensing, each of those programs was designed with a commitment to employing evidence-based programs and services. So Dr. Keats already mentioned the arts benefits in Virginia. We seized upon that opportunity, recognizing that that was an open door to expand our own provision of MAT. And RBHA opened an integrated primary behavioral health care clinic at its main outpatient location just over 4 years ago, and we decided to use that as part of our armament in pursuing OBOTs. We opened an outpatient program, an OBOT program, through our primary care clinic as recently as this past spring. I'm going to turn this over to Dr. May now, who will take you through the rest of our presentation.
And this is Jim May. Thank you very much for inviting us to participate in this. As Dr. Lindstrom just said, we've been operating an integrated primary behavioral health care clinic at our main location since 2014, and we have grown that program fairly significantly as of this spring with the addition of the office-based opioid treatment program. And so that was a critical jump for us into the MAT. Simultaneous to that, we also began providing MAT services on our residential treatment campus in all 3 of our treatment programs and in our withdrawal management program as well. One of the advantages for us jumping in right off the bat is we have been designated as gold standard OBOTS program by DMAS, which provides for good reimbursement rates. And one of the things internally that's been very helpful is we have the same physician providing the waivered buprenorphine prescribing in both the outpatient and residential treatment settings. That becomes a continuity of care issue when you're handing off someone out of a residential treatment program into an outpatient setting for follow-up care, and the fact that we can transfer them from the residential programs to our OBOTS clinic on an outpatient basis and be served by the same physician has been very good for customer service and our commitment to continuity of care. On this next slide, you'll see just a kind of a tabular representation of what all we have and some of the key points that I'll just draw your attention to show you that, A, there's some modest differences, but not tremendous differences between offering MAT in residential programs compared to offering them in your outpatient services programs. So in the outpatient clinic, we have a buprenorphine waivered part-time consulting physician. We're probably looking for another one to join us, another part-time in the near future. And we now have a full-time buprenorphine waivered nurse practitioner. And we have additional ones in training that as we grow the program will be very helpful. On the residential campus, we have the same buprenorphine waivered physician. And there he's assisted by a nurse manager and the nursing staff in the withdrawal management unit and the other residential programs. We're planning on a buprenorphine waivered nurse practitioner on the residential campus sometime in late 2018 as we continue to grow that service as well. Inductions on the outpatient services side generally happen on Mondays, but sometimes they happen on Wednesdays as well. and ongoing medical follow-ups outpatient happen mostly on Wednesdays. We're about to expand that because we've kind of filled up our calendar on Wednesdays at this stage of the game. And at the moment, our therapy groups for that population are happening on an outpatient basis on Mondays and Wednesdays. And we're going to start at least one additional day in the very near future. Typical induction on the residential campus can actually happen on any day of the week, but generally happens on Monday through Friday, which tends to be when we get our admissions to the campus. And it usually starts while they're in withdrawal management services before moving on to residential. And then obviously the medical follow-ups for people that have been inducted can happen on an ongoing basis any day after induction. And that's really just a matter for the prescribing physician to arrange that schedule. And now obviously therapy groups in the residential campus are happening daily as part of the residential treatment services that are being offered. On the next slide, I think one of the main points that we want to make here is that we jumped into this, as Dr. Lindstrom said, trying to not just expand but also to improve the services available to people with substance use disorders in our community. And some of our underlying assumptions that behavioral health care is health care. But far too many of the people that we have been serving with SUD disorders have not taken care of their health for way too many years. Our experience with the outpatient clinic over the last 4 years demonstrated that our consumers actually love being able to receive their medical services here on site at the RBHA. And so that was a process of our whole organization becoming more comfortable with offering primary care services. Consumers are more likely to recover if they're provided evidence-based practices, and we are committed to providing evidence-based care here at RBHA. And addiction is a healthcare disease, and medication-assisted treatment is the evidence-based practice, the preferred evidence-based practice, the most researched evidence-based practice, as you saw from Tammy's slides earlier, for the treatment of opioid addiction. Next slide, we talk about some of the barriers that we had to overcome to be able to do this. And I can't guarantee you that we've overcome them on a permanent basis, because the first one is the staffing shortages. There's a limited number of physicians that are willing and interested in working with our treatment population. We're engaged in regular conversations here about how do we entice additional physicians to come work with us, with our population. And I can't say that we've solved all that at this point in time, but we're working on it all the time. At the present time, there's only a small number of nurse practitioners and physician assistants that have pursued becoming waivered for buprenorphine in the Commonwealth of Virginia. We certainly want to be the first ones to find them when we do. And part of how we're doing that is we've set ourselves up as a training site for nurse practitioners. So we've been doing that for about 2 years, and obviously we're trying to interest them not just in becoming nurse practitioners, but also in becoming buprenorphine waivered after they become nurse practitioners. And just as hard as any of those is finding registered nurses. We've had to employ all kinds of recruitment strategies, and I can't even count the number of interviews we've had to do to bring in the registered nurses that we need. And that's actually become almost an ongoing recruitment, constant recruitment for nurses. Staff attitudes is one that's kind of hidden below the surface, but it's one you need to pay attention to. Staff of all stripes may come in the door with pre-existing negative attitudes towards medication-assisted treatment. We've encountered that with counselors, with nurses, behavioral health techs. And what we've learned and what we've implemented to overcome that is you need to recruit for the desired attitude. So we literally are asking questions during the interview phase for all positions about people's beliefs and understanding about medication-assisted treatment. We found that the people who have biases against medication-assisted treatment will let those biases be known during the interview process if you ask the right questions. So we have certainly been doing that on an ongoing basis. And then time and space limitations in a large residential setting where it looks like we have a lot of space. The majority of people coming in the door have opioid addictions, and with the implementation of medication-assisted treatment, we are starting to develop lines at medication administration time during the day. And so medication administration is taking longer than before, and we've had to build around that time and space-wise in the residential services environment. Looks like one of the questions we've been asked is whether buprenorphine is the only medication available. The answer, I guess, to that is sort of, kind of. We have a certain small number of clients in the residential environment who are on methadone, and those would be people who were on methadone prior to arriving at the residential program and would be engaged with one of our contracted methadone service providers. And between the treatment team's assessments and the physician's assessments of those clients, they were not being stabilized on an outpatient basis with methadone, but rather than take them off the methadone, we bring them into the residential treatment environment, and then the methadone is delivered to the residential site for those clients. So buprenorphine is certainly the main MAT that we're using, but there are some clients on methadone as well. We have not jumped into the long-acting injectable naltrexone, mostly for cost reasons, but also having to have somebody clean for 10 to 14 days before being able to get them started on the medication is a tremendous barrier for us, because we're getting people that are literally shooting up the morning before they're admitted to residential treatment, and they're looking for help as soon as they come in the door. So that's not proven to be practical for us at this time. Doesn't mean we wouldn't. And the practical aspects of getting started on it have been barriers to us. Some of the other things, you need to have good pharmacy access. You either need a pharmacy on site or you need 24-hour delivery to your residential environment. And we're fortunate to have both. On the outpatient setting, we have a pharmacy on site. People can pick up their meds at the same location as right after seeing the doctor. And on the residential campus, we have a pharmacy that delivers to our residential programs throughout most of the day hours up to about, I think, 8 or 9 o'clock at night. So that's also proven to be very helpful as well. Medication storage, obviously when you're doing methadone or buprenorphine, you're going to need protocols and some specialized storage that's required for those medications. We have safes that we're using in addition to the separate lock locations. So they're kind of double locked, if you will, and then each individual patient's medications are locked in medication bags as well. So I guess we're triple locked on that. And scheduling for post-residential treatment on an outpatient follow-up care. What I would like to say about that is if they're living in Richmond, it's very easy for us because we can transfer them directly to our outpatient clinic. When we get referrals from out of catchment area that are pretty far away, we can work with the managed care companies, care coordinators, but our own case managers as well, work to try to find someone who is a prescriber in their home. Move to in our programming now is to try to determine that even before they're admitted to our facility, if at all possible. The last thing we want to do is get somebody started on a medication that they can't continue on after they leave us. So that's just something I would throw out as not too much of a cautionary note, but something that will have to be dealt with if you're planning on implementing MAT in your residential treatment environment. So the question I think we just saw has to do with security for our facility. We don't have separate security staff at the residential location. We do have that here on the outpatient basis. We have security staff at our front door, and the clinic itself is located a floor above, so somebody has to get on the elevator or stairs to get upstairs. On the residential campus, as I was mentioning before, we're kind of triple locked, separate medication bags in a locked room in a safe in that locked room. So, and we actually rebuilt the room before we got started, so it's a very secure environment. So I think that's the answer to that question. And I'm going to hand this back to John. He's got an additional piece to that.
Yeah, the only thing that I would add is in Virginia, if medications are delivered for a specific individual to a third-party site such as us. One has to be registered as an alternate delivery site, and the storage capabilities and security have to be visited by and improved by the Virginia Board of Pharmacy.
Looks like we have another question here. Could the presenters describe their process for identifying and addressing health-related social needs? All individuals at the time of admission are assessed along numerous dimensions. We call it our biopsychosocial assessment. That happens right up front. Each person who's admitted is assigned either a care coordinator or case manager, which there's not a whole lot of difference between those two, whose job it is to help with ancillary referrals for more specialized medical care that people need, in addition to immediately beginning plans for post-residential treatment housing for those individuals. Housing for anybody of lower income in Richmond, Virginia is a major challenge, and so I don't want to sound like we've got that solved in every instance or that we even have ideal solutions for every client that comes through the door, but we are working on it all the time.
The other thing I would add to that is only recently in the last year, funds became available to us to build a permanent supportive housing program that is targeted for all of the disability groups, but we're really focusing intensely on people with serious mental illness and co-occurring conditions.
I think with that, we're finished on our part, and we can turn it over to the next person. Yes, I'm here.
Jim and John, it's Matt. I just wondered, aren't there additional funds? I can't remember if it's now established or proposed in current legislation for housing for pregnant women who are addicted.
Unfortunately, the only part of the arts benefit that we had taken some issue with is it didn't make special provisions for pregnant women. So basically, we're being paid at the same rate for the pregnant women coming in. Same thing for the women coming in with their children in the treatment. We have a very large separate residential program just for women that is under major renovations now. So our capacity to serve is probably about 1/3 of what it will be when we're finished with the renovations. We're kind of moving beds around as the construction crews work on the other parts of the building. When we're finished, we should be able to house between 54 and 57 individuals, either children or the women themselves. But I think implied in your question, Matt, is that women who are pregnant and women who come in the door with kids obviously cost us more to serve. We have child care staff that are working with the kids during the day when the mothers are in treatment. And there's a number of prenatal appointments and so forth we have to transport people to during their pregnancy. So there's some hidden additional costs that go with that. Does that answer your question?
Yes, thank you.
There are funds available to us, block grant funds, through the State Department of Behavioral Health, which is what we're using to cover those ancillary costs. But also, a lot of those dollars are being used for people who have no insurance whatsoever. Virginia, as you know, doesn't has not expanded Medicaid, so not everybody has a payer source when they come in our door. In fact, we're probably in the SUD services, less than 30% of the people coming in the door have Medicaid or any other insurance. So we have a pretty large population that we have to treat that have no payer source. Any other questions?
Thank you.
Thank you. With that, I think we can hand it off to the next presenter.
All right, thank you so much, Dr. Lindstrom and Dr. May. That was a very informative presentation. So our next presenter is Susan Spies from Phoenix House. She's the Director of Nursing of Phoenix House.
Hi everyone, my name is Susan Spies. I'm the Director of Nursing at Phoenix House, which is a substance abuse treatment center in Arlington. I'm a little under the weather. I apologize for my hoarse voice. I might have to pause every once in a while to get a sip of water. Please let me know if you can't hear me well. I mostly want to talk about the realities, just as our colleagues are doing here, of implementing medication-assisted treatment in a residential treatment program. We have residential and also other levels of care, partial hospitalization and outpatient, and treating with medication-assisted treatment along the continuum of care has been a very, very crucial part of our treatment process. And I think that the most important thing that we do to achieve this is by having consistent messaging from all levels of our care, all employees throughout the organization, giving the same message to all the patients that are walking through the door about medication-assisted treatment. So, I mean, as we've learned, it is the gold standard of treatment for opioid use disorder, and everyone needs to be giving that message. Treatment is just not complete without it. A patient's stay with us begins with the assessments department, and they're assessed for an appropriate level of care in our facility or a referral out, and we start there with raising awareness of MAT even before their admission. So anybody with opioid use disorder receives materials on medication-assisted treatment and education on it, and what we offer at Phoenix House, which includes buprenorphine products as well as naltrexone, although the vast majority of what we use is buprenorphine. The next step in the process of admission to us is to the medical department, and all patients, as soon as they arrive, receive a full history and physical from one of our nurse practitioners or physicians. And, you know, right away we're discussing the willingness of the patient to get on buprenorphine. If it is indicated for the patient, we can prescribe it right away and get that started, depending on their last use of opioids and if there's any other contraindications to the medications. But we really try to not delay that prescription, because it provides a chance for the patient to, you know, go through very uncomfortable withdrawals and walk out the door if we don't get that started as soon as possible. And then our medical department is also available every day for frequent follow-up and dose adjustments until we get that right. So we found that to be a very important part of our MAT therapy. Also, we have, as the patients are attending treatment groups, we have many groups on medication-assisted treatment, so they're getting that message from the groups as well. This includes a weekly medication group with a psychiatrist who frequently discusses buprenorphine. There's lots of questions from the patients about these medications. And then also there's frequent discussion about medication-assisted treatment in individual sessions and group sessions with counselors, including family sessions. So we found that it is really important to get families on board with medication-assisted treatment of their loved ones with opioid use disorder. As you may know, having buy-in from families and who they may be going back to after treatment is really crucial, that they're able to give a consistent message about the importance of taking medication as well. And then on down to the residential staff in our facilities. I really think that the residential staff is the backbone of our residential treatment programs, and I think people call them, these employees, different things in different places, but basically the people that are the employees that are looking after the patients 24/7 or with them all the time, moving them through the day, and, you know, having informal discussions with them around the dinner table, you know, in the hallway, and even just the smallest comment about being on Suboxone or, you know, do you think you're really clean when you're on Suboxone, or do you really think you need that, can derail a patient from wanting to take that medicine and being compliant. And so we really target a lot of training towards our residential staff who often have a history of addiction themselves. And that kind of leads me to my next slide, which is that, you know, all of this really requires a team approach and winning the hearts and minds of all of the levels of staff, from the very top to the residential staff. And we do that by just constant training, really. And as my previous colleague mentioned, you know, we interview for that too as well, and attitudes toward medication-assisted treatment. But, you know, the training goes a lot like what we've learned here today, which is addiction is a brain disease. These numbers don't lie. Leaving residential treatment on medication-assisted treatment absolutely reduces the risk of not only overdose but death when people leave on buprenorphine maintenance. And so we do that through, you know, quarterly trainings, through yearly trainings, and everybody is required to do that, from the HR person to the nurse practitioners. So, and then we also try our best to maintain a culture of practicing evidence-based care in our facility. We want to be doing the latest and greatest in treating opioid use disorder, and we have that as a goal, as so that we can really try to start making a difference in this epidemic. Sometimes all the training in the world and the culture in the world doesn't always change minds. At times it takes comparing for employees to compare real-time successes of specific patients that have chosen to get on medication-assisted treatment versus those who have not chosen, who have not made that choice, or who can't be on it because of some sort of contraindication. And so comparing how these two different patients are doing in treatment, their ability to focus and cope with disappointments or frustrations is very stark. And so being able to discuss that with some of the employees that are have a few more questions about medication-assisted treatment is often very helpful, and I encourage that. We also have, you know, monthly goals of the percentage of our patients that discharge from our facility on MAT. In December, our the percentage of patients that discharged with opioid use disorder that discharged on buprenorphine was 73%, and we are very proud of that and want to make that higher and higher, and we share that monthly with all of the staff so that we can help them correlate what we are doing in treatment to actual lives saved. And I've found that that's really something that people can gather around and work towards. And obviously, having physicians and nurse practitioners and or physicians and physician assistants who are buprenorphine waivered is very important to getting this done. It is much easier to doing this than having to refer somebody out for these medications. Some of these barriers that I've listed here are ones that we've already gone over, so I won't go over them in too much detail. One of them, as I said, is that a major barrier is the patient themselves and their families. Those that believe that they're just switching from one drug to another, or their families at home are giving them inconsistent messages from the staff in treatment about the Suboxone or buprenorphine that they're being prescribed. So again, we use a team approach for this. We are discussing this with them at all levels, and including in the family meetings. We find that to be very important. Another common barrier for us is insurance rejections and pre-authorizations that delay the time when we can start the patient on buprenorphine. A couple of the things that we've done to try to improve this and smooth this process is, one, becoming a preferred provider for Virginia Medicaid in order to reduce the rejections that we're getting on our buprenorphine products. And also with our private health insurance companies that we contract with, we just are constantly speaking with them and lobbying them to go ahead and let their buprenorphine prescriptions be filled without requiring pre-authorization. We also have encountered barriers with the criminal justice system. Some of these systems have some outdated beliefs about the use of Suboxone. We have discussed with them in stakeholder meetings about, this being the gold standard of treatment, and that we want everybody to be able to have buprenorphine. And sometimes, and that changes minds. And sometimes it really just takes advocating for one patient at a time, literally. And, that can be just, we identify a patient who wouldn't ordinarily be allowed to be on Suboxone or buprenorphine, and discuss this particular patient who we really think will not survive unless we're able to put them on MAT and discharge them on MAT. And it can just take, having that discussion with their parole officer, judge, to try to convince them to allow this one person to do it. And last but not least, pharmacy services. We reviewed that already in the previous presentation, but I am very jealous of those residential treatment centers out there that have a pharmacy in-house. I think that's wonderful. We have a relationship with a local pharmacy that delivers to us, and that relationship is invaluable if they can help you problem solve with insurances and costs. And I really encourage anybody who's trying to do this to make sure you've identified a pharmacy that can help you through this process. And last but not least, I just want to touch for a moment on responsible prescribing, so that we are all, as treatment centers in the state and all over the country, practicing responsible prescribing for buprenorphine. Checking the prescription monitoring system has been very important to us, and not that for residential treatment it necessarily changes your care of the patient. If somebody has been out there filling loads of opioid prescriptions, they need to get on medication-assisted treatment, and seeing that in the prescription monitoring system isn't going to change care necessarily, but it certainly helps inform care. The same with doing urine drug screens. We do not use those as a form of punishment or a gotcha type of situation. It is to help inform care. We want those urine drug screens to be positive for buprenorphine and negative for everything else. And so that helps inform us how the patient is doing, particularly on an outpatient basis. Providing close follow-up consistent with the level of care. So as I said, in residential treatment, we can be following up with patients every day, and on down the line through PHP and other outpatient levels of care, consistent with how frequently the patient comes. And then making referrals to responsible buprenorphine prescribers. We have the same challenges as the previous presenters at Phoenix House. But again, discharge planning starts from the moment of admission, so that as soon as we know where that patient is going to go after they leave us, we are trying to get them an appointment and ensuring coverage of their buprenorphine supply to get them until the next appointment, so that they have enough medication and they don't run out. Running out of buprenorphine before the next appointment, before the next prescription, it can be absolutely devastating. And really completely derail the treatment process. And then the very last thing I wanted to say, which I forgot to put on this slide, is also remembering to prescribe Narcan to patients with opioid use disorder when they leave. Even though they're doing well, patients have relapses, big and small, and that is a life-saving medication that's important that they have access to. Okay, and that's the end of my presentation. It looks like I have a couple questions. One is Phoenix House able to admit individuals at any time of day? Yes. Yeah, we are. We can admit 7 days a week. We find, like the presenter before me, that most admissions occur Monday through Friday, but we certainly do it on the weekends. We find that most of our admissions tend to come in late afternoon and evenings. That just seems to be the pattern that we see, and we will take them at any time of day. We have 24-hour nursing on site, and so that's not a problem. And then another is, could requirement of pre-authorization for buprenorphine be a violation of the federal parity law? I don't know much about that. Do any of the other presenters want to answer that question? I certainly think it could be. It really is a barrier to treatment.
Yeah.
But
Can folks hear me? I think I'm coming through. I'm not per se expert on federal parity, but in general, it's parity with the medical benefit. And obviously there are many medications that are used for purely medical purposes that have prior authorization requirements. So having prior authorization requirements per se would not seem to be a violation of federal parity. That said, there's some, in my point of view, complexity about prior authorization requirements for buprenorphine. Here in Virginia, we at Virginia Medicaid have put, and in turn our MCO partners have placed, a prior authorization requirement for buprenorphine. But a lot of that, it was really at least for two reasons. One is the prior authorization request form, while burdensome, does require the person requesting it to basically attest that they are following evidence-based requirements, that they will commit to regular and that have been performing regular urine drug monitoring, just one example. So it's meant to try to reinforce appropriate care, and it's part of the incentive that we have put in place to try to encourage our waivered prescribers to become part of a preferred office-based opioid treatment setting, which is what we call an OBOT, which involves co-located behavioral health care and counseling, care coordination. One of the in sweeteners to become an OBOT is the requirement to complete that form is waived. Likewise, as Susan mentioned, we have set that same frame up for residential providers, and there's a pretty straightforward process. Phoenix House has done it to become a preferred buprenorphine provider for residential settings, which also waives the requirement for Virginia Medicaid members for a prior auth for buprenorphine. So it's probably a long-winded answer to a simple question, but I felt the need to sort of set some context. And happy to follow up if there are further questions.
Thank you, Dr. Keats. There's a couple more questions here for you, Susan.
Yes, I'm seeing one right now. Why is buprenorphine the primary medication used in residential MAT? How is it addressed if a person is not successful with buprenorphine or may be better suited for methadone? We certainly encourage, buprenorphine, methadone, or an naltrexone for medication-assisted treatment. We find that buprenorphine is the preferred drug because, preferred to methadone because it's easier for the patient to get that and not have to continually go back to a methadone clinic daily or every other day. patients tend to prefer that. They see the methadone setup as kind of a little bit of a barrier to care. And then for patients who buprenorphine is not an option, naltrexone is a great option. Besides that, we see more success for our patients leaving on buprenorphine than on naltrexone. We see less, just anecdotally, we see a lot less relapses and overdoses for our patients that have left on buprenorphine. Next is, are all of your admissions put into a maintenance program, or is there a protocol for a long-term taper? That's a great question. 5 years ago, we used to do tapers for everybody. And as research has evolved and our treatment has evolved, we've been doing much more maintenance. There are certain patients that are appropriate for a long-term taper, but we do believe that, staying on buprenorphine maintenance for a year to two while the patient is getting the rest of their life in order, going to meetings, learning their coping skills, going to getting a job, getting their relationships back in order, and then slowly coming down off of it has been more successful. Patients that we've done long-term tapers for include people who are coming in and need help with the physical withdrawals, and so coming down slowly off of opioids, but are going to be unable to stay on buprenorphine. So, for example, if they're going to have to go to jail after treatment, that's somebody that we certainly consider a taper for. And I think that's all the questions I see. Please let me know if I'm missing any.
I think you got them all. Thank you so much.
Thank you.
And we'll have time at the very end if people think of more questions that they want to ask. But at this point, I will move on to our third presenter, Life Center of Galax, and Bonnie Stewart, the Director of Counseling Services, and Tammy Eichner, the Director of Nursing.
Hi, I'm Bonnie. I'm the Director of Counseling Services. I just wanted to say that Life Center of Galax has been providing residential services since 1973. And we actually implemented a MAT program in 1999. About a third of our patients last year were on some kind of maintenance program, and we're projecting probably about half this year. We treat approximately 2,600 patients a year, and so we're right in the forefront of all the methadone and the MAT treatment. And we're licensed and accredited as an OTP. And so we're anxious to learn as much as we can and continue with the services. Tammy, our Director of Nursing, talks more about the actual MAT program.
And thank you for having us today. Why don't you go ahead and click to our first slide. The reason that we decided to go to the MAT program is because there was the benefit of having patients be able to focus on their treatment and recovery without having the cravings. And so we did realize that there are some struggles, as people have mentioned before, with getting patient buy-in, getting employee buy-in, and getting family buy-in. But they have to be able to have those tools built into their recovery without having the cravings overtake their ability to focus on those things. Finding outpatient providers, again, some of the challenges that we have, just as some of the other presenters have described, it is difficult in our area with us being in the lower portion of Southwest Virginia. We don't always have patients who come to us that live here. We do have clinics in our area that provide the MAT services, but they don't all come to us from our area. So having the discharge planning is one of the biggest parts of our care. As soon as they walk in the door, we start talking about what are your needs, what type of assistance do you need, is it something that we're going to be able to get you back in your area with, do you need the longer acting medications like the Vivitrol, or is it something that we need to get you in with a clinic, what services are available in your area, which helps us to find if they need to be on the buprenorphine or the methadone, or if we need to get them on the Vivitrol. So discharge planning is vital with our patients. We do offer unlike some facilities who have the either-or approach, we do offer maintenance in several different options. We have methadone, buprenorphine, Vivitrol, which is more of the abstinence-type blocking medications, and Revia. Some of the best part with getting patients to be compliant is getting staff buy-in. A lot of people don't understand that you just can't quit cold turkey with everything. So we do a lot of staff education, and with the staff education goes with getting the patient to see that the staff are bought in with it. If the staff are bought in with it, then the patients have an easier time. Then the family has an easier time. We try to educate the staff that it's not only a treatment process, but it's also about continuing their care after they go home, unlearning old behaviors, being able to have them focus on their post-acute withdrawal symptoms, being able to focus on things other than their cravings. It's not intended to be a complete solution, but it is something that can help them get to the next stage in their recovery. Some of the things that we have found through the questions that have been asked so far, with the security measures, we do have a few different things that were challenges. We definitely wanted to make sure that with having these medications in our building that we had a secure environment. We have the medications in a safe behind a locked door that is alarmed in another locked location. We have security staff, we have a staff diversion plan, and we have a special way that we administer the medication where we have extra staff on site that watch the medication being administered. Some of the other questions that were asked, as far as deciding what is appropriate for the patient to take, whether it's buprenorphine or methadone, that starts when the patient comes in. We look at what the patient's signs and symptoms are, what's available at the patient's location where they're going to be discharged to. If it's not a good fit for the patient once they start taking it, we let the doctor make the evaluation to see what is more appropriate for the patient. And we just try to match what is best for the patient and their needs. We do admissions at all times of day and night, 7 days a week. Most of our admissions do come in usually they start coming in around noon, but we do admissions 7 days a week. And then as far as addressing and identifying health-related needs for our patients, we have a very comprehensive assessment process. We do a pre-admission assessment, which begins when the patient calls in wanting to know if they're a good fit for our facility. Then when the patient arrives, we do an intake assessment. Then they get a nursing assessment. The physician or nurse practitioner sees them. They get a comprehensive H&P. Then they have a psychosocial assessment done with the clinical staff. We pull records from previous admissions. And again, we just start discharge planning as soon as we get them in the door.
One thing that I think is unique, Tammy, this is the other Tammy, if I understood you right, is that you offer all three medications. You're an OTP, offering methadone, also buprenorphine, and Vivitrol, and I was wondering if you could talk a little bit about how important you think that might be or might not be for other providers that are thinking about that.
I think that it was unusual when I first came to this facility to have that many options, but it is wonderful for our patients because it's one of those things where one size doesn't fit all. You have the patients who come in and, we do also do just detox. We have some patients who come in and they only want detox, and there's no talking them out of that. Then you have some patients who come in and they really want to go on maintenance, but they don't tolerate it well. So going on maintenance is not an option for them. Or for whatever reason, they live in an area where it's not conducive for them to drive 2 hours to their closest clinic. So Vivitrol is an option. So just having those different options for the patients gives them the flexibility to be able to get their recovery. Whereas if you only have that one option, sometimes it doesn't really give the patient every opportunity that they may need.
In Life Center of Galax, this is Bonnie again. We're licensed as a substance abuse residential managed, and we manage detox services. The substance abuse residential managed withdrawal service can be involuntary. Yeah, we take TDOs, basically. We're licensed as a substance abuse partial hospitalization program for adults, and we're licensed as a substance abuse medication-assisted treatment service for adults. And I would like to just comment on something that was said earlier about getting over some of the stereotypes or some of the barriers to treatment as far as substance abuse treatment as a whole. And one of them is that getting people on board, staff and other people on board, because I know in the old days treatment center treatment there was always this, total abstinence. So that is something that we're working on a regular basis, because this is also new and trying to get this out where people can accept it and educating families on it. So that is a challenge that I've seen, but my staff here are just really getting on board with that, and we're breaking through those barriers.
One of the questions that just popped up was about dental care. We do provide dental care for our patients, not here on site, of course, but we have the wonderful opportunity to take our patients to local providers. That's one of the things, unfortunately, with some of our clientele. They do have dental issues. A lot of our patients have neglected their other issues in their life, their health issues, to pay for their drug of choice. So when they get to us and they start feeling better, then those other health issues start popping up and they can't ignore them anymore. So we do have some providers in our area that have agreed to see our patients, and we do take them to dental appointments, the health department for issues that they may have. If they have an issue that we need to take them out to be seen for other medical needs, if they have a fall for whatever reason, have a sprain, strain, things like that, we can take them to local providers. And our doctor is a medical doctor as well as an addictionologist, so she's able to prescribe. So we're very lucky in that aspect too, that a lot of the care can be given here on site for things like, unfortunately right now we're going through some flu issues, like a lot of facilities. So she can prescribe and treat, and we don't have to take our patients to the emergency room or to other places to get the care that they need. But when we do need access to things like dental care, we have a lot of places in the area that are willing to work with our patients.
Maybe you could talk a little bit more about the transition. You mentioned that a significant proportion of your patients are coming from out of state or more distal locations, and the importance of setting that up as soon as people come in, the discharge planning. Can you talk about the communication that goes on maybe even after they transition? Is there communication back and forth about issues that might arise, or medical history, or any lessons learned about making those transitions work?
One of the very first things we do before the patient ever gets here is we try to get medical records, especially if they're coming from the referral source, if it's a hospital or another care facility, so that we have records prior to them arriving. We also have an alumni coordinator who is a support person who makes calls to the patients after they leave to check up on them. They do calls every other week to check up on the patient, to see how they're doing in their recovery, reach out to them to see if they need help, if they feel like they're relapsing, what tools can they give them to prevent the relapse, if it's preventable, if not, how to get them back in treatment. And then they do a 1-year support after they've DC'd call as well. They also follow up on their aftercare and their appointments.
Any other questions from the audience, or any other comments or contributions from our other presenters at this point? I see someone typing
This is
here.
Matt Keats. Can you hear me? With Matt Keats with Virginia Medicaid. I just wanted to say a special thank you to the representatives from RBHA, Phoenix House, and Life Center of Galax. You guys really are at the forefront in many ways with your programs, and in particular in making MAT available. And at DMS, we really appreciate that on behalf of our members. Thank you.
And I will echo that. Credible information, and thank you so much for taking the time to share that with folks. So that concludes our webinar today. The webinar will be posted on the RTI website, and we thank you all for your participation and attention. Have a good afternoon.